Today we'll discuss prioritization in cancer management. Let's start with key assessment findings and red flags in cancer nursing. When you're assessing cancer patients, certain patterns and warning signs show up over and over again. First, consider pancreatic cancer risk. The patient most at risk is an elderly African American male who smokes. Other risk factors include alcohol use, obesity, diabetes, pancreatitis, a high-fat diet, chemical exposure, and previous abdominal radiation. If you see a patient with those characteristics, that's your red flag. You'll also want to assess for subtle signs like jaundice, unexplained weight loss, or vague upper abdominal pain. Those are often the earliest clues before diagnosis. Now for spinal cord compression. Back pain is the earliest and most common symptom. It happens in about 95% of patients who develop this complication. If you hear a cancer patient say their back pain is new or worsening, that's an emergency cue. If untreated, it progresses to weakness, bowel or bladder changes, and then paralysis. The moment you hear back pain in a cancer patient, think spinal cord compression and report it immediately. Next, let's review hypercalcemia in bone cancer. When calcium levels rise above 11 or 12 milligrams per deciliter, that's a life-threatening emergency. These patients often develop confusion, muscle weakness, polyuria, and sometimes heart rhythm changes on the monitor. You'll see this most often in cancers with bone destruction, such as osteogenic sarcoma. Now let's talk about tumor lysis syndrome. This is a major NCLEX favorite because it's life-threatening and entirely preventable with good nursing care. When tumors break down rapidly, the patient's potassium and phosphorus levels rise while calcium levels fall. You'll notice muscle cramps, arrhythmias, or confusion, and you'll always check electrolyte levels first. If you get a morning report with multiple oncology patients, the one with tumor lysis syndrome comes first every time. Next, think about a patient with liver cancer who suddenly shows decreased level of consciousness. Here's the exact sequence you follow. First, check responsiveness and level of consciousness. Next, administer oxygen and check pulse oximetry. Then, take full vital signs, followed by a bedside blood glucose check. After that, make sure IV access is patent, then review electrolytes, and finally check the ammonia level. Always think airway, perfusion, and metabolic causes before assuming hepatic encephalopathy. Finally, let's talk about SIADH caused by lung cancer. These patients present with weight gain, weakness, nausea, vomiting, and sometimes confusion. Lab results will show hyponatremia and low serum osmolality. The initial order you should anticipate is fluid restriction, not a fluid bolus. Now let's move into interventions for chemotherapy and radiation. First, vincristine, also known as Oncovin, can cause neurotoxicity. If a patient reports tingling or numbness, that's called paresthesia, and it must be reported immediately. Mild fatigue, nausea, anorexia, and vomiting are expected and can be managed with supportive care. But paresthesia is a sign of toxicity that may require the drug to be held or the dose adjusted. Next, always prioritize the white blood cell count in any patient receiving chemotherapy. A low WBC count, particularly low neutrophils, puts the patient at high risk for infection. Notify the provider if the total WBC falls below 3,000 or if the absolute neutrophil count drops under 1,000. That's when protective isolation and strict precautions become necessary. Let's talk about chemotherapy administration safety. Only certified chemotherapy nurses are allowed to handle and administer these drugs. They can be absorbed through the skin or inhaled during preparation, which makes them hazardous. If you are not chemotherapy certified, your immediate action is to notify the charge nurse. Do not try to just finish the infusion. Safety always outweighs convenience. Now let's cover radiation therapy. If a patient's radiation implant becomes dislodged, act quickly but safely. Use forceps to pick up the source, place it into a lead container, and maintain your distance. Then, notify radiation safety. Never attempt to reinsert it manually, and don't delay. This is a top NCLEX safety question. Next, let's talk about bleeding precautions for thrombocytopenia. You'll use paper tape on fragile skin, provide a soft toothbrush or oral sponge, avoid aspirin and alcohol-based mouthwash, and never overinflate blood pressure cuffs. You'll also pad the sharp corners of furniture. And you'll absolutely avoid anything rectal. No suppositories, no rectal temperatures, and no tampons. For oral cancer care, the LPN can safely administer medications such as antacids or sucralfate suspension as ordered. The UAP can assist gently with brushing and flossing, but the RN is responsible for explaining when brushing or flossing is contraindicated and for coordinating with the provider about saliva substitutes. And finally, in end-of-life care, when a patient becomes short of breath and anxious, morphine elixir is the first-line therapy. It relieves the sensation of air hunger, eases anxiety, and improves comfort. You should not call a rapid response or prepare for intubation. Comfort, not aggressive resuscitation, is the goal at this stage. Now let's move into patient teaching and emotional support. A common situation is anxiety during teaching. If a patient with gastrointestinal cancer becomes angry or threatens to leave, anxiety is the priority diagnosis. You can't teach effectively until the patient feels emotionally safe. Once they calm down, then you can begin explaining the procedure. Next, let's look at cancer prevention and screening education. The nurse practitioner explains diagnostic tests and screening procedures. The nutritionist focuses on diet, especially reducing fat and preservatives. The LPN may prepare posters or handouts about the 7 warning signs of cancer. The nurse practitioner teaches how to perform breast and testicular self-examinations, and the RN focuses on strategies to reduce risk factors such as smoking and obesity. Here's what that means for screening. Women aged 21 or older should have annual Pap tests, even if they are not sexually active. African American men should begin prostate-specific antigen testing at age 45. Everyone aged 50 or older should complete an annual fecal occult blood test and colonoscopy. Mammograms begin at age 40, and women older than 65 with 3 normal Pap results can safely stop screening. Now let's talk about breast cancer risk counseling. Advanced practice nurses and registered nurses can teach self-examination and make nursing diagnoses. LPNs can reinforce teaching and remind patients about follow-up mammograms. Advanced practice nurses and physicians perform the actual breast exam and interpret mammogram results. Next, we'll talk about smoking cessation. The LPN can explain how to apply a nicotine patch. The RN designs the quit plan, identifies relapse triggers, and provides counseling. Smoking cessation is an important nursing intervention and a key core measure in prevention of lung cancer. And finally, let's look at coping in grief. When a patient says something like, "I want control over my own life and death," assess immediately for suicidal thoughts. That's a red flag statement. If a patient refuses treatment or plans to leave the hospital after a new diagnosis, ineffective coping becomes the priority nursing diagnosis. Your best tools are active listening, exploring feelings, and connecting the patient to support resources such as social work or counseling. Now let's talk about delegation and scope of practice. In cancer care, delegation questions are all about knowing who can safely do what. The UAP can assist with oral hygiene for patients with esophageal cancer and may perform daily weights only when directed by the nurse. The RN, not the UAP, observes the patient's response to feedings. For gastrointestinal cancer, the LPN can administer enemas and antibiotics as prescribed. For oral cancer, the LPN can give medications like antacids and sucralfate, while the UAP helps the patient with brushing and flossing. LPNs can also prepare educational posters or standard materials such as the 7 warning signs of cancer. They can gather supplies for protective isolation, take vital signs every 4 hours, and report any temperature over 100.4 degrees Fahrenheit. They can also teach standardized tasks, such as applying a nicotine patch. But remember, monitoring fatigue patterns, assessing skin reactions to radiation, or observing emotional distress must stay with the RN. The UAP may report intake from the meal tray, but it's the RN who interprets what that means for the patient's nutrition status. Here's a quick way to remember delegation rules. The UAP assists but does not assess. The LPN reinforces but does not teach new material. And the RN assesses, plans, evaluates, teaches, and triages. In other words, delegate what's stable and predictable, but keep anything that's critical or changing. Now let's move into safety and prioritization. When several patients need you at once, you must know who to see first. During morning assessment, the correct priority order goes like this. First, assess the patient with tumor lysis syndrome because that's life-threatening. Second, assess the preoperative patient, since surgery is soon and preparation can't be delayed. Third, assess the patient with breakthrough pain, since pain control may require provider input. And finally, the patient with anticipatory nausea and vomiting, because that's distressing but not urgent. For hepatic encephalopathy assessment, follow this sequence every time. Check level of consciousness, provide oxygen, take full vital signs, check blood glucose, verify IV patency, review electrolytes, and then check the ammonia level. Now let's look at environmental and protective safety. For neutropenic patients, the UAP can take vital signs every 4 hours, report any temperature over 100.4, gather supplies, and practice good hand washing. However, they cannot assess for symptoms or diagnose infections. Patients with neutropenia require protective isolation, a private room, limited visitors, and no live plants or uncooked foods. Next, consider patient placement. 2 patients who have had palliative surgeries, such as tumor debulking and spinal laminectomy, can safely share a room. But patients with neutropenia, or those who have had bone marrow transplants, must be placed in private protective isolation. Now for chemotherapy exposure precautions. Because these drugs can be absorbed through the skin, always use gloves, gown, and mask, and follow the facility's hazardous waste disposal policy. Only certified nurses handle cytotoxic medications, no exceptions. If a radiation implant becomes dislodged, the first action is to pick it up with forceps, place it in a lead container, and call radiation safety immediately. Never touch it with your hands or attempt to put it back. And for professional conduct, if you discover that 2 nurses have switched assignments because one does not like caring for certain cancer patients, your first step is to talk with that nurse privately. Find out what's behind the behavior. Address the emotional or educational issue before taking disciplinary action. The goal is to guide and teach, not punish. Now let's summarize important medication and symptom management pearls. Vincristine is used in chemotherapy but can cause nerve toxicity, so teach patients to report any tingling or numbness right away. Sucralfate suspension coats the mouth and esophagus to protect mucosa and should be given before meals. Don't give it with other medications. Morphine elixir relieves dyspnea at the end of life. It's used for comfort, not just pain control. Aspirin increases bleeding risk and should be avoided in thrombocytopenic patients. Nicotine patches help patients quit smoking. The LPN can teach the application process. Antacids help with oral cancer discomfort, and the LPN can administer them while the RN evaluates effectiveness. Now let's go over the top 10 NCLEX never miss points. Oral hygiene can be delegated to the UAP, but assessment must stay with the RN. Anxiety blocks learning. Calm the patient before teaching. Pancreatic cancer risk is highest in older African American male smokers. Paresthesia from vincristine requires immediate provider notification. New back pain in a cancer patient means possible spinal cord compression. Hypercalcemia in bone cancer is an emergency. Hydrate and notify the provider. Tumor lysis syndrome always requires electrolyte monitoring and renal protection. If a radiation implant comes out, use forceps and a lead container. Morphine elixir relieves air hunger. It's comfort care, not resuscitation. And if you're not chemotherapy certified, do not administer the drug. Notify the charge nurse right away. Finally, let's summarize the prioritization patterns you'll see most often. When airway or oxygenation is compromised, as in a liver cancer patient with altered consciousness, start oxygen and assess immediately. When circulation is threatened, as with tumor lysis syndrome, give fluids and check labs. For neurologic concerns, such as spinal cord compression, report back pain right away. For safety risks, like chemotherapy exposure, only certified personnel should handle the drugs. When infection is the issue, as in neutropenia, use isolation and reinforce hand hygiene. And when the problem is psychosocial, such as poor coping or suicidal statements, assess and intervene promptly. To wrap up, here's the key message. Cancer nursing combines technical precision with compassion and critical thinking. Your ability to prioritize, delegate safely, teach clearly, and recognize early red flags can save lives every single day. Stay alert for subtle changes, protect yourself and your patients, and always lead with calm, confident care. If this helped you master another concept, hit like, share it with your classmates, and subscribe for the next Dr. Atkinson lesson.